I'm Rajiv Gupta. I'm a consultant pediatrician from Barnsley, and I'm very moved. It's a very fantastic vision for the NHS of future, and I think it's very good to have a clinician having the decision making together with the patient and integration of the services, which I think should have happened long ago. I wanted to ask you a question that, when you initially proposed, like, clinicians taking over or general practice, which it was in past, there was a lot of excitement, but over the period of time there have been withdrawal of the support, like from the Royal College of General Practitioners, Royal College of Pediatrics, BMA, which look slightly different than what I would have expected. So the first question I wanted to ask is your reflection on why is it happened, and could there be something that could be done? And a short question, secondly, is about the secondary care. They still feel left out because it's all happening there. We don't really know what's happening. And then although in theory, as a secondary care clinician or as a consultant, you can go there and make changes, but it doesn't look like the news is coming to us, and we are kind of set on the background and have very little ability to influence the care it should happen. So.
Thanks. Two good questions. One over there, if we take the microphone to over there, and then I think the third one. Have we got a second microphone? No, just one.
I think we know that gentleman.
Right.
Hi, Johnny Marshall.
Troublemaker, yes.
Currently Interim Partnership Development Director for NHS Clinical Commissioners. I just want to explore this legacy a little bit more, because I think for many of us, we feel the legacy isn't in the balance sheet, but it's in the fact that over the last certainly 20 years of my time in general practice, we've recognised the need for a significant change in the model of healthcare in order to meet the challenges that we face, which is getting increasingly pressing. And I completely agree with you that this is a conversation that we as clinical commissioning groups need to be having with our local public to explain the benefits of the changes that we have in mind. And in reality, we're used to having difficult conversations with members of the public. It's something that we're actually quite good at. But I think it's really important, I guess what I'm asking from you is it's really important that we have that political leadership that says we are empowering these guys to look very carefully at our system of care. There will be some really difficult decisions to be made about how we provide care differently to deliver the benefits we wish, and actually be there supporting us as we look at that national expression locally by leading a national discussion about the sort of NHS we're going to need for the future. That's the support we would like from you.
Thanks. And third and last over there.
Yeah, the third question is about reducing health inequalities. One of the best ways to do that is to give poor people more money in their pockets. What could Mr. Lansley do to help close tax loops for companies and private individuals and send that money to the poor communities that really need them?
Quite three rather different sets of questions.
Okay, may I, Dr. Gupta first. Let me be clear. I don't think, during the passage of the legislation and so on, I don't think actually support for clinical commissioning went away. I think what happened was essentially, and if you look carefully, the BMA, in a sense of to be fair to them, there's a degree of consistency. They were against the idea of choice and competition when the Labour government were promoting it. And so they were against choice and competition when they thought we were promoting it. I think I won't bore you with the kind of why I think actually the way we're doing it is better than the way Labour did it. That's not the point. The point is they took that. And the Royal College of General Practitioners, likewise, never said they were opposed to clinical commissioning. On the contrary, they support it. The BMA say they support clinical commissioning. And I do hope actually all of you don't, now I think as future commissioners, as clinical commissioners yourselves, I don't think you should think you're doing anything which the Royal College or the BMA would disagree with. On the contrary, I actually think the things that most worried the Royal College and the BMA, that services in the NHS would be privatised, that suddenly patients would be charged for services instead of them being free, or that competition would be used in circumstances where it would lead to any dilution of the quality of service provided to patients. None of those things will happen. And actually some of those things, you're in charge. Competition, in that sense, you only deploy competition when you think it's in the best interest of patients. And the way you do it, particularly through any qualified provider, can actually arrive at a position where I think it simply empowers patients. You don't really even need to think of it as a competition process, because you don't have to have tendering and all that. You simply say, whoever is best qualified to provide a service for our patients, that's the right person the patient should go to, which doesn't seem to... And I do hope actually we get beyond. I think perhaps to an extent we are now getting beyond some of that kind of ideological debate around the bill into what in truth is the future that I think we're all looking for, which is clinical leadership in commissioning. And I just say on the second, Johnny, on political leadership, yeah, it's very difficult. I think we should convey the message strongly, nationally, and it's not just me. Actually, the NHS Commissioning Board is a stronger place to be able to do that. You know, when you look at what, it's not precisely the same thing, but when you look, for example, at what Bruce Keogh has been doing in terms of, with his colleagues of advocating across the service, that the NHS must think of itself as a 24/7 organisation, and we should design ourselves around that concept. When you look at what the Commissioning Board and ourselves are going to do in relation to the rollout of the 3 Million Lives campaign and putting telehealth solutions, we can do some of that. But you're absolutely right. Alongside that, we have the capacity to say to the public, not least through the media and Parliament, that services are going to change. That sometimes, if you really do want to have, and actually, of course, you say to patients, do you want to go to where the care is really going to be excellent? They'll say, yes, please. It's part of this point about choice. They're willing, it's not just elective choice. If you say to them, do you think an ambulance should take you to a place, if you've got an aneurysm, where there isn't a vascular surgeon, or to a place where there is a vascular surgeon? Well, the answer is yes, I'd rather go to a place with a vascular surgeon, thank you very much. And they will understand that. What then you understand is that the public don't see, as a consequence of that, why if they don't have a heart attack or an aneurysm or a brain injury or trauma, they don't understand why their local A&E department shouldn't still be there so they can access it in order to have the other 85% of things that happen there taken away from them. So I completely understand people, because I remember there was a physician in Leeds who did a kind of spoof survey with his patients written up in the old Hospital Doctor magazine that's now long gone, who said he did a survey of his patients and he asked them first by whom they would like their care to be provided, and there was a range of options, and then secondly where they would like their care to be provided, and likewise a range of options. And the conclusion he reached based on the public response was they would like to have a world-class physician available at the end of their street. Well, actually, we've got a fantastic system which people envy us, because through general practice, quite often people have access to somebody who can get them the right care at the right place at the right time. And if we're out there arguing for a right place, right care, right place, right time philosophy, and we do that nationally, and you explain it locally, I think probably we're getting to the right place. What can I do to help put more money in people's pockets? Actually, the NHS can, as a government, one of our objectives is precisely to put more money into people's pockets and to deal with some of those underlying inequalities. Where the NHS is concerned, it will not surprise you that one of the central features of our approach to public health is a recognition of what are the social determinants of health, and access, not living in poverty, people being in employment, the economic circumstances in which people live are an instrumental part of that. Absolutely. But the NHS can also be part, as David Nicholson was showing in the Innovation, Health and Wealth, we can be part of the process of enabling people to be in employment more. The NHS is capable of being a spur to growth. We're out there at the moment, for example, through things like NHS Global, the NHS is providing expertise and ideas around the world. The NHS as a source, I was talking about big data, through things like the Clinical Practice Research Data Link through MHRA, we have NHS linked data sets across a fantastically good information system, 52 million people, ethnically diverse and with a more or less complete health record across the population. It's a fantastic means by which we can energise research in this country and bring research expertise from around the world to this country. We can be part, and we are working hard to be part of the process by which we stimulate growth and wealth as well as health.
Thanks. Well, let's, any more questions? We've got one here, one... Where are the microphones? Should we take these two in the middle?
This one in the front and this one over there.
And then one at the front here and one over here.
Hi, I'm David Kelly, I'm a GP, I'm Chair of North Kirklees CCG. I wanted to ask about the variation in primary care. Obviously one of the key tasks we've got is to actually reduce variation in practices, and we can do that from a clinical perspective. The two things I wanted to ask was, what will the government or Mr. Lansley do about the variation in funding for general practice? We've got a range of funding in our practices from £50 a head to £120 a head. And that's actually impacting on what we can do. We've actually got no contractual mechanism to actually alter that. And secondly, he states, how and when will we get the funding for that to actually improve practices that we need to actually deliver the services we need to provide?
Okay, and next, over here. Where's the microphone?
Yeah, it's okay. We'll start with
one here. Great.
Joe McGilligan, I'm GP and Chair of Easy Dog CCG in Surrey. John Wilson tells me that I'm actually the only clinical co-chair of a health and wellbeing board in the country. I believe there's only one public pound and that can only be spent once, and everyone, as you just heard, feels their budgets are wrong. How do you see the partnership between a means-tested social care and a free healthcare working out when the pinch really comes?
Sorry, say the last bit again.
How do you see the partnership between means-tested social care and free healthcare working out when the pinch really comes?
Right, good question. And one over here. Okay, over there.
Rashmi Soni, GP in High Wycombe and Chiltern CCG. Just wanted to pick up on a point the Minister made about budgets and that the money allocated to the CCGs wouldn't go to pay off debts of trusts and would be, say, for commissioning alone. I just wanted to ask what legislative steps can be taken to, or what steps the Minister would be taking to ensure that happens.
Okay, two questions about budgets, one about inequalities.
On the first, with the, I won't, in a sense, you tempt me to talk about variation across the country, and I do think actually the Atlas of Variation and the publication of data and the openness with which we're approaching the publication of lots of data, including in general practice and with the active cooperation of the Royal College, I think it will expose a lot of variation and it will help to drive out unwarranted variation and achieve improvements. You touch on two particular issues. The funding to individual practices, obviously it's part of the primary medical services contract. From my point of view, if I could arrive rapidly at a situation where practices were through the primary medical services contract, general medical services contract, were paid equitably, equally, I would love to do so, but actually there's all sorts of negotiated contractual changes that are a part of that, including things like MPIG and so on. You know, they are part of the negotiation we will have with the GPC, the General Practitioner Committee. From our point of view, we want to make progress on that because it doesn't, from our point of view, make any sense for there to be some of the variation you're describing in terms of funding for the patients that you look after under that contract. For the NHS generally, the commissioning board's responsibility for the commissioning budget will be to secure, through its allocations, equal access for equal need. And that hasn't always happened in the past, and it will happen in the future, and it will be much more straightforward to do because we will separately be allocating resources for public health, which are essentially based on, as we said the other day, on standardised mortality under the age of 75 as a proxy measure for relative poor health outcomes, which are often very much related to indices of multiple deprivation. But the budgets you'll get will essentially be about the burden of disease in your area relative to other areas. So it should, I hope, move over time to something that is more equal. Estates is tough because we've gone through a process of identifying all the estate that transfers to providers. We're left with what will be part of the NHS Property Estates Company. From my point of view, the next thing to do, and we will be part of a conversation we'll have, is to try and work out how can we, through the capital funding that is available through the department for the NHS, the rest of the NHS estate, give you access where you need it, and what's the basis on which you will access capital funding through us, because capital funding is still, I confess, a difficult part of the whole process of managing the NHS budgets. When the pinch comes, how do we make these two things? Well, there's one or two answers. I mean, for some people, the answer will be, for example, access to personal health budgets alongside personal social care budgets. Everybody in social care should have access to a personal budget if they want one by April 2013. Patients on continuing health care, we're intending to achieve that. For patients with some long-term conditions, it will be appropriate. Beyond that, actually the answer then really for the greater part is about working on joint commissioning. And even if you don't pool budgets, even if you don't actually create a single commissioning structure, the relationships you establish between health and social care, as has been demonstrated in some places like on Torbay and others, you can see how that can achieve substantially better outcomes for patients and break down the barriers. It doesn't require structural and organisational change to do that. It's actually fundamentally about the relationships of building services around patients to make that happen. In the Chilterns, now I'm trying to remember, the lady from the Chilterns was asking me about, forgive me, you're asking me about... Oh, debts, yes, well done. Well, actually, the legislation already will do this. The legislation is very clear that, unlike primary care trusts, you're not, as it were, receiving the money for the whole health economy with a responsibility to manage the health economy. You're receiving a budget in order to deliver the best possible care for your patients. Now, you may, in certain circumstances, agree that you want to pay more than tariff for some things in order to retain access to a service or whatever, but you're not going to be, in that sense, obliged to do so, and monitor their job. And until the trusts become foundation trusts, our job in the Department of Health is to make sure that where there are unsustainable providers and those legacies in terms of debt on the provider side, it's our job to manage those. And it's our job to deal with that. And I do want you just to be focused on how do we deliver the best possible care using the commissioning budget we've got for our area.
Well, thanks, Secretary of State. I'm afraid that's all we've got time for, as they say.